My name is Angela Hill, and I'm the Professor and Associate Dean of Clinical Affairs at the TGIF College of Pharmacy in Tampa, Florida at the University of South Florida. I'm also the Project Director for WeCARE, and you'll get a chance to learn today what WeCARE stands for. And I'm also proud to say that I'm one of the 50 Hoops Legends, and I get a chance today to facilitate today's program. The title of our program is Leveraging Community Engagement to Assist Researchers in Clinical Trial Recruitment and Retention. And we have garnered quite an interesting panel of individuals to lead us into the discussion. And so we encourage everyone to pay attention, to be prepared to answer poll questions in the end. But certainly what we hope to do is enlighten you about the importance of having diversity in clinical trials and some opportunities that we can certainly support the research mission. I'd like to, before we start introducing individuals for the program, allow my pastor, Pastor Quincy Stratford, to lead us in an invocation.
Thank you, Dr. Hill. Let us pray. Father, we're so grateful for your blessings, your grace and your mercy. Father, we're thankful for WeCARE, the Lord, and the knowledge and the awareness that it's creating. Father, I pray that you bless our time together. Bless us to be enlightened. Father, I pray that the knowledge that we learn, that we'll turn into wisdom, and put what needs to be in practice, dear Lord, to make this life more meaningful and more joyous. We thank you. It's in your blessed Son, Jesus' name we pray. Amen.
Thank you, Pastor Stafford. Now I would like to talk a little bit about what we're going to do today and introduce some very important people. Just want to make sure that everyone, can you see my screen? Hopefully you're seeing my slides. Great, I saw a head nod. So I wanted to talk to you about WeCARE as a resource for addressing health disparities in healthcare and supporting recruitment and diversity in clinical trials. I was actually commissioned to take on the second commandment of 10 that we were challenged with as legends by Mr. and Mrs. Sanders. So we have number 2, thou shalt not see minority recruitment as a problem with them, but instead rather a problem that we can solve in our own departments and in our own efforts. And this is a spinoff from the first commandment, which challenged us to take it to the streets. And so today, I think that WeCARE is in a position to certainly share with you how we've taken it to the streets and what we're doing by leveraging community resources and connections. And so today we have with us the dean, the founding dean of the TGIF College of Pharmacy, as well as the executive director for WeCARE, our precious Dr. Kevin Snead, who is also a 50 Hoops legend. We also have Mrs. Nina Naz, who is going to come from you, and she represents one of our key community partners, Moffitt Cancer Center, and she actually is the director for non-therapeutic research. We also have Mrs. Sharon DeVore, who is a certified clinical research coordinator that actually practices in the Tallahassee area, and she'll be sharing her perspectives about research, recruitment, and retention of minorities from her perspective as a clinical research coordinator. And I will periodically be commenting on the reason why WeCARE is so important in some of the activities that we do. So you'll hear me talk about WeCARE quite a bit today. And WeCARE is just an acronym, and it stands for Work Group Enhancing Community Advocacy and Research Engagement. And back in, I think it was around 2015 or so, Dr. Snead decided to continue some of the work that had been started through a health center for health equity with Moffitt and the College of Public Health here at the University of South Florida, and repurpose the mission. And he'll tell us a whole lot more about that. But there were several individuals that were involved, and I wanted to give them some acknowledgement today because they did a lot of work. And prior to WeCARE, the focus on a lot of what was being done in the Health Equity Center centered around cancer disparities. And so individuals like Dr. Maisha Standifer, Dr. Desiree Rivers, Mr. Hiram Green, Dr. Austin, as well as our own Mr. and Mrs. Sanders, they were essential in allowing us to definitely share the message about the importance of cancer disparities and us needing to close that gap. But WeCARE actually remains the only living residual from those efforts. And Dr. Snead decided that WeCARE would expand its mission. And so we have continued to work with Dr. Austin. We can still have Mr. Hiram Green. Sometimes we call him pastor, sometimes we call him doctor. Sometimes we give him all kind of honorary degrees, but we continue to work. Now we have an army of student ambassadors from both College of Pharmacy as well as the College of Public Health. And we still work directly and indirectly with Dr. Standifer and Dr. Rivers. But I just wanted to kind of introduce our group to you so you can really kind of understand. And primarily our main mission has been to advocate for and oversee research activities within the community. And WeCARE has taken on the responsibility of making sure that both the community understands research processes, but that our researchers also have the opportunity to understand the importance of culturally tailored approaches, particularly when it comes to recruitment as well as retention. And so we have several objectives, and Dr. Snead again is going to give us a much more detailed look at as to how he came about the inspiration for WeCARE, as well as some of the other work that he's done in the community. So with that, I thought I would try to share with you what we call our hype video, so you can appreciate a little bit about what we do in WeCARE, and hopefully the sound will cooperate as well. Can you all hear it? Okay, great.
Dr. Hill, I don't think the video is showing.
So well, why do we care? Why we care? Why this program? We want to improve health outcomes.
Okay, so you can hear it, but you couldn't see it that time. All right, hold on. We're going to start it over.
You may need to switch over the share to.
Yes.
Yeah, I was gonna say you have to switch to the YouTube and then optimize it for video share.
Okay. So let me see. I'll go back and start. So if I share screen, share sign, optimize video clip, I think I'm there. Let's see now. What are you
Yep.
seeing? Right? Can you hear it?
Yep.
So well, why do we care? Why we care? Why this program? We want to improve health outcomes.
The collaboration between USF Health's Tanasia College of Pharmacy's WeCARE program and Reach Up Incorporated aims to bridge the gap between underserved communities and access to care. WeCARE's mission is to increase the representation of diverse populations in clinical research. It starts with rebuilding trust between academic and clinical institutions through educating and empowering the community, and then providing research opportunities along with protection and advocacy for the participants.
They want to hear the story from folks who have been through a clinical trial.
You have to share all of that information with everybody.
So take the opportunity to have a better quality of life in our communities. Join us. Okay, so what I would like to do now is introduce you all to the man behind WeCARE, Dr. Kevin Snead, who, as I mentioned, is the founding dean for the Tanasia College of Pharmacy. He's also a pharmacist like myself who specializes in ambulatory care. He received his education from Xavier, University of Florida, University of Central Florida, and along the way, not only did he get a pharmacy degree, but he also has a specialty in immunology and microimmunology, and that has benefited us extremely well in the last several years with the pandemic. Dr. Snead also completed a residency in ambulatory care, and so he's what we consider a metabolic syndrome specialist. He is also unique in that he still practices as a pharmacist, actually goes to the clinic, I think oftentimes a little bit more than I do sometimes, but he still is hands-on and in the trenches as it relates not only to patient care, but teaching, as well as training students. But he has an extreme profound love for community and giving back. And so with that, I'd like to introduce my boss, my friend, and my colleague, Dr. Snead, and he is gonna tell us a little bit more about WeCARE. So Dr. Snead.
Dr. Hill, thank you very much for that very kind introduction. I'm just going to take a few moments here and talk about the background of WeCARE, and from a historical standpoint, I'm really also going to share a little bit about how we even encountered the great Sanders team with 50 hoops. So let me go ahead and share my screen here and get started. Okay, there we go, and share something. Okay. So again, one of the most important things to understand about how we evolved, and one of my real passions, was the fact that we are moving into a DNA and RNA-based age of research and clinical outcomes. And so I felt it was very important that we make sure that all groups are represented. And I'll share more about an interesting meeting I had just this morning with a group from England. So historically, I started back, we had a program called In Shape. And one of the main premises of In Shape was the fact that even if we have health disparities, and even if they are true, and we know that there are historical aspects to it, that we can't let that become a barrier moving forward to overcoming some of the historical terrible aspects of health inequity. And we can't let that prevent us from getting good health for our families today and in the future. And so bullet point number 2 really does begin to show exactly what Dr. Hill was mentioning when we talk about partnerships. The only way that we're really going to get out of that, no one entity can do it alone. No academic entity, no nonprofit group, industry, nobody can do it alone. We have to build partnerships if we really want to engage people and improve lives in many communities. And so again, just kind of showing a little bit of the history here within Shape, and this particular poster and research project I did, it really kind of set a pathway in terms of understanding the mentality of what happens in many of our minority communities. And so without going into this entire study, what really happened was the fact I had a simple question: do you have diabetes, yes or no? And as it turned out, about 30% of the people that said I don't have diabetes actually did have diabetes. Now that's not really, we can understand how that may occur, but as I delved deeper, it really began to understand that people, it wasn't that they just didn't know, but they didn't really want to know and didn't trust the environment enough to be honest to themselves or anybody else. And so we went from there to, as Dr. Hill mentioned, we developed the Center for Equal Health. There was a partnership between USF and Moffitt on a $6.5 million grant over 5 years. When that came to an end, we had developed such a good cohesive momentum moving into the community that we actually wanted to continue it. So we started WeCARE in 2014. We continued doing CAM events with 50 Hoops in 2015. And so here we are today. But I wanted to go back and again, Pat, I just wanted to show this video just for a few moments. I'm going to create a visual. I love creating visuals. I'm going to bring up 3 names. Number 1, I want you to think about Tiger Woods. Number 2, I want you to think about Beyonce. And number 3, I want you to think about Lenny Kravitz. Very often, we tend to think of people as being all the same. But then, if we go back and take a look at the parents of each one of the 3 people, they had different genetic makeups. And so just because we term them African American and we think that they may look alike, they are probably very different in how they would respond to a particular medication.
African Americans are dying 10 years earlier than their Caucasian peers. Medical professionals are now using pharmacogenomics to help predict how certain DNA code sequences will react to medication.
If we don't have enough genetic patterns to test in the clinical trial, then we cannot be assured that that medication will work for them. We have to stop treating people as if they're all the same and really get down to what we call individualized medicine so that we can treat you for the individual that you are.
We need our DNA in these trials. When my daughter and my grandson are on a surgery table and there's something being administered to them, I want to know that at least 10 to 12% African Americans have been tested on that drug. This is a mutual responsibility.
Pat Sanders directs a national organization working with USF Health and Moffitt Cancer Center to help improve the diversity of clinical trial participation in Tampa Bay, where signups are low, as little as 1%.
What are the solutions? How do we address it?
In 1993, the FDA began to mandate the active inclusion of women and minorities into clinical trials.
With transparency and truth, integrity, you will have people running to you. Instead of looking at all the negatives from the past, to make it a stepping stone to induce us into the future to make things better for everybody.
So as you all can see, I just wanted to take a walk down memory lane for a few moments and really show, and I'll show it here again in a moment, that there's nothing new about the relationship between 50 Hoops and their support nationally for improving the number of underrepresented groups in clinical research. Again, so there's a lot of reasons. Again, there's a lot of words here, but there's a lot of reasons why we haven't been able to gain better traction. But it doesn't mean that we can't not improve that moving forward. And so we have to work really hard to make sure that we can accomplish that. One of the things I really often like to share with the public and share with people in our communities is that it's not your imagination. This has been going on for a very, very long time. In the Institute of Medicine report, all the way back in 2002, you see highlighted, they made a statement, and it was one of the more powerful statements at the time. This study represents the nation's potential to ameliorate a set of problems that are over 394 years old for Native American community and 382 years old for African American communities. And when they made that statement, it actually began to acknowledge the long-term history of what's happened in our country, but also gave us hope moving forward that we can work together to overcome them. And so WeCARE, again, we've heard the acronym. It's a community-based participatory research program. It really does focus on achieving health equity through educating, engaging, and empowering the community. It's really important to understand that as part of our mission, we've worked initially when we had the grant with Moffitt Cancer Center, we had a very narrow focus. We focused on the African-American populations almost exclusively, and then we focused even more on men with prostate cancer or prostate cancer screening awareness. When we transitioned over to WeCARE, now we go to any and all diverse communities. So we have the Latino community, the Asian Indian community, the Native Indian community. We have so many different people. We will work with anyone to improve relationships with that community so that we can hopefully one day engage them for additional clinical research opportunities. Now, one of the unique aspects of WeCARE is the fact that we are not a gatekeeper organization. We're not telling researchers that you have to come through us to get to the community. We want to be a conduit between the researchers and the community. We want to bring them together and make a easier pathway for the researcher to actually overcome many of the historical aspects of what was really challenging and bringing people together. And so, again, when we talk about engagement and empowering the community, once they begin to understand and get to know and hear from the community, have people from the community act on their behalf, and then actually have the researchers come to the community and make commitments for health equity and what we're trying to achieve and put it in terms that we can understand. Now we're talking about building an environment that really will become much more conducive for enhancement of people in our communities. Now, you saw this slide before, but again, one of the most important things here is we as an academic institution, we cannot do anything if we don't have groups like Reach Up Incorporated. They really have been such a strong partnership. And even long before the pandemic, they came and we sat down. They saw the importance of what we were trying to do. And we formed a relationship probably as far back as 2017. So that by the time the pandemic came around, that they actually became our entry point to go into many of our diverse communities, and I mean, an array of communities, and began the COVID education program that Dr. Hill and I have been doing together now to the tune of collectively over 200 programs out in the community. And I put this slide in at the last minute because, first of all, we gather people from the community to act on behalf of the community to interface with the researchers. The gentleman at the far, that's listed on top and at the far right, I put this slide in. He is a dear friend. I had a chance to actually talk and communicate with him just last week in clinic. Dr. Adewale Troutman, he just passed away early on Wednesday morning. And then right below him is Christina Mathis. She passed away earlier this year because of COVID, but they were very instrumental in helping us to develop WeCARE and gain greater immersion into the community and build trust. So very quickly, I wanted to kind of point out a few things about why clinical research is actually so important. Many people ask me all the time, why are these medications so expensive? Well, you know, when you do a clinical trial, they can spend close to $1 billion just to get one medication on the market sometimes. Now, that doesn't justify some of the cost out there, and I'm fighting diligently on behalf of people in communities all across this country, for example, to lower the cost of insulin. Now, there's no reason for insulin to cost as much as it does. However, I just wanted to make people aware that when we talk about doing different phases of clinical trials, and we need to make sure that we have diverse communities, we need to have African Americans, we need to have women, children, we need to have Latino. I need to have people from different socioeconomic backgrounds to make sure we have representation, so that when that medication on the lower right corner here gets approved by the FDA, we have confidence that people from all communities have been tested, and we've been a part of it, and we have a very clear understanding of what we can expect when we actually have problems with our health in our communities. So let me expand on what you saw in that video. Here we have a picture of a very young Tiger Woods, a very young Beyonce, and Lenny Kravitz. And if they all had the very same disease state, can we assure that the medication, if we gave all three the very same medication, would it work? And I say, no, we can't, because actually we take a look at Tiger Woods. He had an African-American father, Asian mother. Beyonce had two, what we would consider to be African-American parents, although I continue to hear something about a little bit of a Creole influence in there somewhere. And then Lenny Kravitz had an African-American mother and a Caucasian father. And so even though the world, when we look at all three of them, we say they're about the same age, they're similarly complected, they belong to the African-American community. In reality, the DNA of their backgrounds and their parents is much different. And so therefore, they may have different reactions to different medications out there. Now, there are ongoing studies right now indicating that we need to make sure that we're focusing attention on African Americans or different ethnic groups, just so we can understand how these medications may be working. And then right here at USF, we took it one step further, and we're now engaged in helping to do translation of that research so that we can come up with therapeutics to make sure that based upon who you are as an individual, that we can make an attempt to predict if that medication is going to be effective for you or not. And I actually had a meeting this morning with a company from England earlier this morning, where we're trying to help bring them here to enhance and do even more in this space. And they were really excited about the diversity that we have here in this area. This is what I call hiding in plain view. We have business models and academic models based on this premise of individualized or personalized medicine. And I'm not going to show this entire video, but very often people want to know, well, what does it entail if you're going to get my DNA, and how safe is it? And we say, well, you know, it's extremely safe. It's just a blood test. And by the way, many of the commercials you see on TV in the evenings have much of this kind of background research that is already being done. So again, I won't show that entire video just for time's sake, but I'll be available to answer any questions that you all might have. And again, I just want to thank the Sanders family. I want to thank 50 Hoops. I want to thank Reach Up. Let me stop sharing here. I just want to, I'm thankful to so many people, because without these partnerships, we could not have done the work that we have done in the past, nor could we do the work that we are going to accomplish in the future, as we again strengthen ties with our partners. I'm looking here with Moffitt Cancer Center and all the great work that they're doing. So Dr. Hill, I'm going to turn it back over to you, but thank you very much for the opportunity for me to share this information about WeCARE.
Thank you, Dr. Snead. And as I mentioned to everyone, we have been working extremely hard to try to continue this mission. Can you see my slides now? Dr. Snead, can you also?
Yes.
Okay,
Yes,
good. Awesome. So you kind of commented on a lot of the activities that we've done, and I too had some pictures with Mr. and Mrs. Sanders and some of the other key people that have either served on our boards or participated in other programmings that we've done. But one of the things that I wanted to kind of bring to the attention of everyone that I think is also special about WeCARE is that we utilize community members for that research review or advisory board. And involve them in a lot of our community interfaces. And as Dr. Snead mentioned, the pandemic has had us quite busy because we transitioned or pivoted to a virtual platform to try to provide a lot of COVID education, but not at the expense of our other health disparate areas that we know impact Black and Brown populations. And so what the pandemic has done for us is given us a wider view and opportunity to talk about a lot of the things that are impacting our communities and certainly causing a lot of morbidity and mortality. And so I wanted to just kind of show you just a few of the flyers that showcase different topics that we dealt with. And I will be sharing later with you all a link to our e-video library that gives you a really good cross-section of the different programs that we've done. One of the other things that we've done to support researchers, particularly in this summer, has been spending time with our researchers talking about implicit bias, cultural humility, and some of the other things that we're going to talk about in today's program. And so thanks to input and guidance from Dr. Deborah Austin from Reach Up Incorporated, as well as Dr. Maisha Sandifer, we have been able to do some wonderful programming for our researchers. And we've garnered probably about not quite 40 researchers that we've been working extremely closely with on a lot of these topics. But the Research Review Board has also been working very hard in reviewing some studies. And so I thought I would just show you a few of the protocols that they have reviewed for us that truly impact the African-American community especially. And prior to this meeting today, I was attending a committee meeting over at Moffitt where they were actually talking about, unfortunately, how prostate cancer is plaguing or the leading cancer in the Tampa Bay area, followed by breast cancer for women. But Moffitt has done a lot of work in the world of prevention for colorectal cancer. And certainly we're proud to say that we supported the Tampa Bay Cancer Network in terms of forecasting their Screen to Save study. We also have been working as well with some of our brain researchers in the area of Alzheimer's research and advertising some of their studies as it relates to prevention of Alzheimer's disease. And then we've also worked with another colleague at our St. Pete campus who was doing a vaccination hesitation study, which actually focused on the perception of the African-American community. So these are both meaningful projects that our research community is involved in. And again, as Dr. Snead said, if it wasn't for our partners, we wouldn't be able to have certainly the presence that we have now. But consequent to the work that we did, as he mentioned, almost 200 workshops, we are expanding our community partners, as you can see in our slides. So we're really, really excited about that. But one of the things that we've discovered as we have been doing these different workshops is that there's still a lot of mistrust in the community when it comes to clinical trials, when it comes to healthcare in general, and we have a lot of work to do. And so today we're going to hear a little bit from Mrs. Nina Nass from Moffitt, who is the director of the Non-Therapeutic Research Office, and she's going to kind of talk a little bit more about what she's seeing from her office as it relates to medical mistrust. She earned her master's in public health from the University of South Florida in 2013 and has a bachelor's also in anthropology from Florida Gulf Coast University. She's worked at Moffitt in a variety of roles over the past 10 years and has a vested interest in diversity within her team. She's an active member of the Black Empowerment Alliance team member network at Moffitt and enjoys educating her staff on how we can gain greater diversity in clinical trials. She enjoys using her knowledge of anthropological and public health methodologies to inform better ways to approach participants in research. So sit back and let's listen to her kind of guide us on a little bit relating to mistrust of the healthcare system. Mrs. Nuss.
Great. Thank you, Dr. Hill. It's such a pleasure to be here today. It's so wonderful to have met you a few weeks ago. We were collaborating on something different altogether, and it kind of led to this. So I'm excited to see all that we can do together. And what's neat is that Screen to Save study with the colorectal cancer is a project that Dr. Guede is doing and that I've actually helped supported. So I apologize. I think I might have just shared the wrong thing. Did you see that, Dr. Hill? Was it the right screen?
No, it wasn't the right one. There
Nobody wants to see my desktop. I'm sorry. Just a moment. We did practice ahead of time, I promise. Right. You can see the right screen, Dr. Hill?
Yes, it's the right one now.
Yay, thank you. Sorry about that. Okay. So thank you all for joining us today. It's my pleasure to introduce this topic that has many layers. As Dr. Hill noted, I am Nina Noss. I work at Moffitt, and you might be wondering what non-therapeutic research is. And it's really cancer prevention and public health. We work in an academic area, a lot of PhDs, some MD PhDs. And what we're trying to accomplish is to make sure that we have health equity, that we have diversity in our samples, and that we are educating the community in ways to stop cancer before it starts. So that's a lot of the work that I do in the community space as well as the clinical areas, and I support the administrative function. So fair warning, I'm not a PhD and I'm not a faculty member, but I'm very involved in the research here, and I'm very excited to do this talk with you today. All right, so this talk actually started last year when we were having a lot of medical mistrust in the community, and specifically with COVID vaccinations, and our employees are always asking about other ways to be educated. So this is a talk that I initially presented in 2021, so some of these topics came from that time. So anyway, when I initially tried to put this together, I was hearing rumblings of people who aren't vaccinated, who are hesitant to come back to work, and hesitant, uncertain of the way that others might respond to that hesitancy. So I heard some discussion as well on the other side of that coin as to why people would choose not to be vaccinated and not understanding that perspective. And at the same time, we're watching talks for Black History Month, talking about how African Americans have had worse outcomes if they were to get COVID, and examples of African American patients that express the need for medical intervention or additional help and have their concerns dismissed, such as Dr. Susan Moore, who passed away in Indiana 2 weeks after she filmed herself from a hospital bed, noting that she was short of breath and needed help. There has been so much discussion about the topic of compassion and inclusion at Moffitt, not only of the 2 or 5 values that govern the way Moffitt culture should operate, but it's also the way that we treat our patients and how we serve. I understand that this might be an uncomfortable topic for some, but I think it's important for us to understand what medical mistrust is in the present and past state. And I realize that there's been so many populations that may have medical mistrust, been discriminated against, or burdened by systemic racism. I have selected a few populations that have been in the news at the time of my original talk, and I'll provide a few examples to bring us to the present state. By speaking about these truths, my hope is that it provides a perspective from an altered lens of how we may be perceived in research or in the healthcare environment. And please know that I'll be using the terms African American and Black interchangeably during this talk. We will then delve into how it applies to potential participants of clinical trials or non-therapeutic studies. I also do have Vivian Cervantes with me today from the Clinical Trials Office, who might be able to answer some questions in regards to clinical trials in particular. I don't work in treatment, We do see a lot of patients, but we don't work in treatment trials. So she'll be here for Q&A as well. So normally talks surrounding diversity, inclusion, or cultural competency are hosted by someone that's an expert in the topic, and you might be wondering why this self-identifying cisgender white female is presenting. However, I've been a research coordinator. I oversee a large group of staff who interact with participants, and we as a collective group see the importance of diversity in our sample for research, whether it be a data analyst, investigator, or coordinator. I started at Moffitt as a research coordinator in total cancer care, which is our biobank initiative, and saw hundreds of patients that were new to Moffitt and witnessed a variety of concerns surrounding participating in a biobank study. That experience gave me a different perspective on the concerns that patients might have. This was back in 2010, and I remember clearly that there were some patients that asked if Obamacare would be notified of anything we find and if we would clone them. And these are things I knew wouldn't occur. However, I had to take their concerns seriously and explain to them what kind of protections are in place to ensure that that doesn't happen. So at Moffitt, I feel strongly that we need to put our patients first and be able to have them bring their whole authentic self to Moffitt. They are engaging in one of the most difficult times in their life, and they deserve to have empathy and understanding of their perspective when they're in our care, or when we approach them to participate in a research study. Our data isn't as strong if we don't provide an open environment for our patients to bring their true self, and along with that, their data. Building those relationships is important so that they can answer the questionnaires appropriately, whether it's for clinical or for research use. It's important for your participants to feel comfortable during interviews, consent processes, and surveys. Science. It's so important to have representation in your research so that we can extrapolate results to the general community. I'll present some data today on Moffitt's data in diversity and clinical research. We do strive to get those numbers higher to make sure that people of all races, ethnicities, genders, sexual orientation are represented. And how can we get a significant p-value when our numbers are low for one population or another? And finally, I'm speaking for allyship. I'm a member of the Black Empowerment Alliance at Moffitt. And over the past year or two, we've heard a lot of talks from diversity about inclusion, and allyship has provided me with the tools that I need to be comfortable with being uncomfortable. I think that this is a great opportunity for others to also do this at their institutions. So I said, why not use them? I'd like to put a disclaimer out there that this is not my personal journey of growth in this is my personal journey of growth in this space, and I hope to inspire others to also be vulnerable, to learn more about themselves, and to be an ally to those that are marginalized. As with medical mistrust in general, we need to rebuild trust with our marginalized populations that have been burdened by discrimination or systemic racism. It's up to those with privilege to rebuild it and lead the path for change, not those that have been burdened by it. And this is not a burden that I have personally experienced. I'll do my best to do it justice. And we will go to the next slide here. Okay, so what is medical mistrust exactly? It is a suspicion of healthcare providers, organizations, and/or systems. Caring for patients and building an efficient healthcare system relies on trust between the providers and the patients. However, historical events, current biases, and perceptions or stigma can all stand in the way of patients seeking the care that they need or being properly treated when they do seek care. Mistrust in healthcare can have big repercussions and can perpetuate ongoing health disparities in clinical care and in research. In a systematic review that I read for this talk, it suggests that mistrust is not merely the opposite of trust, but the absence of trust. And suspicion of healthcare providers can be for a variety of reasons. I think it's important to value the rationale from a healthcare provider perspective or from a researcher perspective. Sometimes things that can shock you because they don't align with your values. For example, I was completely shocked when my husband, here's the handsome man here, told me that he didn't want to get the COVID vaccine when I asked him about getting it scheduled at Moffitt. I asked him why, and he said that he was hesitant since he doesn't trust the government. I asked him to tell me a little bit more about that, and he told me a story about when he was in the Army. And he remembers when he was 19 years old and about to go off to Iraq. They were giving them all sorts of vaccines and all sorts of tests and things like that. So when he entered basic training, he remembers at the time he felt the government had so much power that they could do whatever they wanted, put anything they wanted into his arm, and he had no power to say otherwise. They were being shipped off to Iraq after that in 2002 and were facing bigger challenges when they got to Baghdad. So in this instance, he was mistrustful of the government and not sure that they had properly vetted the vaccine, and were depending on our vulnerability of society in the pandemic, basically using our fear of COVID against us. There are also people that have not had access to proper medical care financially and don't trust the medical system, since the high costs in the US could appear as taking advantage of a basic need, healthcare. There can also be mistrust in the LGBTQ community due to fear of providers' misunderstanding about their particular healthcare needs, fear of judgment, discrimination of their lifestyle. There's also the intersection of medical mistrust and discrimination. So whether it be based on gender, race, ethnicity, disability, or sexual orientation status. There are several instances of this in the past, which I will discuss and give some examples of recent events that can perpetuate medical mistrust. And I'd like to talk about these events in relation to Moffitt's research mission and how we can empathize and start to rebuild trust in these populations. Again, I understand there are so many populations that we could mention here. However, I'm going to just focus on a few for today's talk. But what all these populations I just mentioned have in common are vulnerability, whether it be a power dynamic, financial, fear of judgment, or discrimination. While mistrust is often referred to as a phenomenon existing within an individual or a community, we must rethink this conceptualization and instead locate mistrust as a phenomenon created by and existing within a system that creates, sustains, and reinforces racism, classism, homophobia, transphobia, and stigma. Mistrust of medical advances and the medical professions continue to persist, and is perhaps increasing. So although the examples that I share in this talk discuss different outcomes and populations, they share a message that social inequality drives mistrust. And please ping me, Dr. Hill, about time, because I know that I was given 15 minutes, but I know that Sharon has to talk too.
Yeah.
Want me to skip some slides because I can?
Yeah.
Okay, that is fine. So let's see. I'm going to move here. So intersectionality is something that I wanted to bring up here. So going back to the story of my husband, who identifies as white and almost middle-aged, he has mistrust of the government tying back to his vulnerability as a soldier, growing up without medical insurance. So extrapolate that vulnerability to an example of the social inequity that a Black gay woman might feel. Not only does the Black community have documented historical events of providers taking advantage of them medically, there is stigma associated with homosexuality. There are structural barriers to access and care. Black Americans having greater mortality during the pandemic, having fear of their provider taking them seriously due to unconscious bias, and recent events in the media that have shown people like Breonna Taylor, Dante Wright, and George Floyd die unnecessarily. How would you feel? To me, that is very overwhelming. And I realized that I should have done this here. So when you really stack these up next to each other, the intersectionality of all of those inequalities for that Black gay woman really is visualized right here. So although medical mistrust can occur in any vulnerable population, I think it's really important as a provider, as a researcher, to recognize the intersectionality between different vulnerabilities, barriers, and how those can accumulate over time. So in the example with my white 6-foot-tall, 200-pound husband, although he felt vulnerable in the Army and growing up without health insurance, he had the privilege of looking like the cops or doctors that he intersected with. So we all have vulnerabilities. However, when they're compounded with external factors such as systemic racism, it can really accumulate and have a lasting impact. So just kind of repeating what I said earlier, the thread of this talk about mistrust is vulnerability, whether it be a power dynamic, financial fear, or judgment or discrimination. And that's really important to recognize in your study participant. So really quickly, this is Moffitt's data that we had from last year. We are striving to get better diversity in our sample, and Vivian on the call is actually a full-time person that is dedicated to clinical trial navigation and education here at Moffitt. So what are we doing at Moffitt to actively win back trust with our participants? We are a leader in the LGBTQ community. Dr. Shabath has just finished up a huge study with BMS looking at provider education for LGBTQ patients. Dr. Guede and Dr. Mead, I think Dr. Hill, you're friendly with them. They have an NCA supplement for education and clinical trials. They're doing a lot in the community space. And a lot of our work is really focusing on how we can empower minorities and provide education to ensure that they get the access to care that they need. We also have team member networks at Moffitt to help with that. We also support a DEI enterprise equity support plan, and we have allyship resources as well. So what I told my staff is, how can we win back trust? We want to make sure, this is such an overarching problem, but what I think is really important to focus on is what you can contribute yourself. You can't fix the world, you can't fix what's happening outside, but what you have control over is how you interact with your patients. So at Moffitt, our mantra is that one person can make a difference. Empathize with your patients, understand their perspective, flexing your style and how they respond, and realize that medical mistrust and systemic racism is a current issue and it's not a past one. Empathize with your coworkers that might have medical mistrust, and ensure that you really incorporate cultural competency and humility into your skill set for your patients and for your own professional and personal growth. And I will turn it back to you, Dr. Hill. Thank you so much for having me present today.
Well, thank you so much, Ms. Niles. And you highlighted so many very important topics as it relates to why it is that people don't trust the healthcare community. And I think, unfortunately, that mistrust, like you said, spills over into clinical trial participation. So so glad that both you and Ms. Cervantes are on today's call, but we're going to now listen to another clinical research coordinator. As I mentioned, Mrs. Sharon DeVore earlier, is a colleague of mine from my Tallahassee days, and she's also a licensed practical nurse. She's worked in pediatrics. She started her actual clinical research career over 20 years ago, but she's been working with Dr. Ricardo Ayala, one of my mentors and former physicians and neurologists that I used to work with in Tallahassee. And she has done a lot of clinical trial work in the sphere of epilepsy, multiple sclerosis, Alzheimer's disease, attention deficit disorder, neuropathy, head trauma, stroke, a lot of disorders that oftentimes impact the African-American community. So I thought it would be really good for her to come today and share with us some of the things she's seeing at an even deeper trench level in terms of strategies that can maybe help researchers that might be in our audience today with recruitment and retention. So we'll ask Mr. Adams if you can cue up her slides. And I'd like to introduce Sharon as we continue this conversation. Okay, Sharon, I'm seeing them on my end.
I'm sorry, can you hear me now?
Yes.
Okay. Thank you, Dr. Hill. When Dr. Hill invited me to participate in this forum, I was very thankful that she felt my contributions would be worthy. We both share a long history and passionate dedication to the integrity of clinical trials. Next slide. Will you be changing my slides for me? Okay. And the next slide. Next slide. Okay, thank you. That's perfect. In Tallahassee, our geographical area is very diverse. I believe we're about 27% minority. We also service about a 100-mile radius with the surrounding communities between Tallahassee and Jacksonville or Pensacola, Panama City. So our population in itself is very diverse, but we also pull from those surrounding communities. With that said, I'll say that I have noticed minorities, specifically I'm talking about the African Americans, have not been included in some of our clinical trials, not because they didn't want to. There is definitely there's that category of people, but for those who wanted to, it was because they didn't qualify. Specifically, they did not qualify due to not meeting certain criteria. like a history of uncontrolled hypertension, diabetes, heart attack, cancer in the past 5 years. So they wanted to participate, but because of their medical history or their current condition, they didn't qualify. Clinical trials very strict with regards to medical history. Although, what I would say at this very moment, a greater portion of our patients, subjects in our clinical trials are minority. In our epilepsy trials, multiple sclerosis trials, they are qualifying. Although in our Alzheimer's study, none of our subjects are minorities. And I'm going to loop back around with this comment here. I just wanted to let you know that there is a large population. We do have subjects in our own particular site who do qualify in certain trials, but in other trials, they do not. Next slide, please. Our site, our standard of care is always evolving to include better ways for the lives of our subjects. By doing so, recruitment and retention is enhanced. It is not something we plan, it's not something we think about, because it has become the natural way we run clinical trials. Most importantly, people are listened to. We close our mouths and we let them speak, and we listen to what they're saying. We don't assume anything because they are old, because they're a minority, for any reason. We listen to them and hear what their concerns are. Some questions we might ask right up front is what may prevent you from participating? And then we do our best to meet that need more often than not. Because once a person has found a doctor that they trust or a staff, they'll generally stay with you. For example, we've had multiple patients who were in clinical trials who ended up moving out of state, one to Chicago, well, one down to Miami, which is kind of out of state for Tallahassee. And they continued in our clinical trial. They got on their airplane and they flew up for their appointments. Some had to come once a month, some had to come every 3 months, but they were devoted to us because we were devoted to them. And obviously, well, the sponsor covered the cost of the travel, but they could have picked up with another clinician in their own place, but they did stay with us. Next slide, please. Next slide. Okay. So raising the standard of care for all subjects beyond what is expected according to good clinical practice, we get closer to reaching the sponsor's goal of recruitment and retention. This is a byproduct of our behavior as clinical research practitioners. It often requires committed staff who will go above and beyond their job description. You must hire the right staff and enough of them. It is mandatory that they are culturally sensitive and always treat subjects with respect. Next slide. Oh, okay. Strategies for recruitment. Okay. Strategies for recruitment. The educational approach to clinical trials is multi-layered. The principal investigator communicates with the coordinators. We talk to the nurses of the primary care doctors. Sponsors post advertisements in social media. There are other means, churches, health fairs. The word gets out in the community about trials, and then it is up to the individual and the study staff to communicate effectively. Advertising and posting flyers contribute to engaging the community. But when a person may discuss this with their primary care doctor, it helps a lot if the primary care doctors in general have a positive feeling about clinical trials. It helps if the primary is even vaguely familiar with the trials going on in their community. Next slide. Okay. All right, this is a big one here. Okay. Let's start here. Okay. Recruitment of African American adherence support. Okay. So subjects can be compensated for travel, food, lodging, either with a flat rate provided by the sponsor through a debit card system like ClinCard. Oftentimes, the main barrier to participation has to do with lost wages, time commitment, and transportation. I know there are many other reasons, personal reasons why a person may not participate, but if they do want to participate, this I have found has been quite difficult for patients. So what we're prepared to have in place a system to resolve that problem. We identify their personal barriers. We're prepared, if needed, to hire staff to work late hours because they have to work, or before hours. We work on one weekend a month. We set aside one day if needed. We don't have to overwork our staff to accomplish this. In clinical research, we need to be flexible to meet the needs of minorities who may not have the luxury of taking a PLT day. That's very important with regards to the minorities. In addition to that, educating primary care doctors and specialists about the trial, this can simply be done by sending over the dictation or a note. As time goes by, many doctors involved in just basic patient care will take note that you're a site conducting research and that their patients, who are also your patients, are being well cared for, because they are. And this will boost their confidence in clinical trial process, and they'll have a positive feeling about it. And then in general, they'll be more likely to endorse this to their patients when addressed about it. Now, with regards to medication adherence, helps stabilize hypertension, which would then help qualify the subject for a clinical trial. Okay, this is a prevalent problem in the African American community, and will often disqualify a person from a trial. We address this issue right up front. We engage the partner or the family and discuss the importance of maintaining good blood pressure, and to find out the issue. And often it has to do with forgetfulness or access to the medicine. We solve this problem by giving the patients Medisets. We make a plan to have it filled once a month by their partner, their daughter, son, and it's checked. We have them check their blood pressure for a week, 4 times a day. And then we contact their primary cares if they're still hypertensive, so they can make adjustments. So, for example, we recently had 2 subjects qualify for the study once their blood pressure was under control. And we emphasize at each visit the importance, and we do what we can to stabilize it. And this is greatly appreciated by the subject. So what I'm trying to say here is that it happens often that the minority and African American doesn't qualify for the study because their blood pressure is not under control, their diabetes is not under control. Well, sometimes it's very easy to fix that. The subject may say, yes, I wasn't able to get it, I haven't taken it for a week, or sometimes I forget. Well, we get that all cleaned up, we have them come back in a month, and we do the screening, and their blood pressure is good, and they can go into the trial. So we don't just write it off, is what I'm saying. Okay, your blood pressure is too high, you don't qualify. Your diabetes is out of control, you don't qualify. No, we take care of it, and they're happy, and we see them month after month, and always checking on them, and things are good, and then they qualified. So once you do have a person who's qualifies in all angles except for that, especially in with minorities or people with those kind of problems, we do like to address that. Next slide, please. Next slide. Okay, retention. Okay, right. So when a person, oh, you can go back one, please. You can. Thank you. Involving more than just a potential trial volunteer. So when a person comes in, we ask for them to bring a partner, bring a friend, bring their sister, bring the family, whoever you want. This is highly encouraged from the very beginning. The subject might miss something or not ask a question because they're reluctant, but by having an advocate to stand with them provides comfort for them, and this does help with recruitment and retention. You must be well informed and ready to address all questions and concerns. And the principal investigator is, of primary importance. At our site, our investigator sees each patient at each visit. It could be 5 minutes, it could be 20 minutes, but he's always there. They always see his face. And if he's not there, I reschedule the patient for a different date. This is number one with retention. At our site, we have 100% retention. I cannot remember the last time a person dropped out of our clinical trial. They just don't. We take good care of them, and that's what they want. They want to see consistency and believe that we are taking very good care of them. We always want to validate the person's concerns. We listen to them. We ask questions. We're very sensitive. For example, I don't assume anything. Everybody's needs are different, and we're sensitive to the way we ask questions. I don't ask a person, do you drive or do you work? I want to know what their schedule is, so what can I do to help them? But instead, I might say, what is your daily schedule? And when they report to me, well, I have to take care of my mother, or I have a job. Well, we take care of that problem right up front. We do a lot of things to help the person qualify for the trial, give them, a good shot at it. Because in our hearts, we do feel that it is in their best interest to be a part of one of our clinical trial programs. And transparency, everybody has touched upon this. We are very transparent at each visit. We take the opportunity to remind them of the procedures for the day. We let them know what to expect at their next visit and ask them if they have questions and concerns. We very much try to help with those items. And next slide, please. Yes. So, right. Recruitment and retention of minority participants is based on trust, rapport, relationships, giving it 110% and always, looking out for them. And finances matter. We have to, in our clinical trials, of course, it does not cost anything. Labs, MRIs, doctor's visits, everything is free, phone calls, everything is free. But you have to understand that minorities and all people have to work. They might work long hours. So you have to have a plan in place to cover the cost of transportation, food, lost wages. That goes a long way with people who might be financially insecure. There are some medias for that. ClinCard is something where money just goes right on a debit card. The person gets it loaded at every visit. This is done by outside agencies. Recruitment can be done primarily for us. It is our pool of patients. We know them. These aren't people that are unfamiliar with us. So most come from our own practice, but some hit upon us through social media, through recruitment sites, and we have a lot of people who seek us out for clinical trials through these. So I think I've hit upon everything. Again, thank you for letting me contribute. I hope there are some things that you may take away from what I've just spoken about. Thank you.
Well, thank you, Sharon. And I do actually think You did share some very valuable information. We did have one question from Ms. Eloise Square asking if how much of the non-participation was a result of the choice of African Americans. And I think you kind of sort of answered that most times it's because they may not qualify due to maybe not managing their chronic health problems correctly. Is that the right assumption?
Yes, and keep in mind too that these are people who come from, we're a neurological group. They're already a part of our practice, the majority of them. So Dr. Ayala has over the years incorporated, he sees 30 patients a day for 30 years. So he has quite a large base. People know him, they trust him, they've stayed with him. And so it's not as much. Of course, there are people who say, I will absolutely not participate. Do not speak to me about that again. And we respect that. And I do not speak about it again. That's their personal choice. But what I'm referring to are those who do want to participate. The two barriers would be their current medical conditions, but we don't just let that make them not qualify. We clean it up. We get them to a point where they can participate. And then the other would be financial. And I don't mean money in their pocket. They don't have jobs maybe where they can take a lot of time off, and clinical trials do need that, but we have a plan in place for that too. So we those are the two efforts that we see make a difference in including people who want to participate in the African American community, help them to do so. Yeah.
Well, thank you. I think you gave some really practical retention as well as recruitment strategies. And certainly we thank you, Ms. Nas, as well as Dr. Snead for your insights. So kind of as we wind down, one of the things that I wanted to kind of hit on, Sharon, that you talked about was in terms of people's status of health. And one of the things, unfortunately, that has happened with the pandemic is that we see a lot of people, unfortunately, between quarantining, telehealth, and things of that nature, paranoia related to the pandemic, people haven't been getting screened, particularly for cancer and other things as much as we like, and not necessarily maintaining, their health. And so we've noticed a decline in things like cancer screenings and health visits and things of that nature. And so one of the things that WeCARE is doing is a project with some of our community partners at Moffitt, where we're going to try to encourage people to be a little bit more cognizant of their health needs. And so we're calling it, and I'm just gonna go down to it and then I'll share again. We're calling it, our Cancer Prevention and Wellness Initiative, where we're really advocating for people to remember to check the blood pressure and take their medication and help with adherence. And certainly we're encouraging things like tobacco cessation and other wellness screenings, immunizations, and the like. So what WeCARE is continuing to do our education piece. And so I just kind of wanted to say, as I close out, and we thank our speakers for all the valuable information that you shared with today, that we just want everyone in the 50 Hoops community and who are on today to know that WeCARE does truly care. And so again, as I mentioned earlier, we have an e-video library that kind of contains past recordings of programs that we've done for both community members, healthcare professionals, researchers, and clinicians, the like, all kinds of programs, and we encourage you to get them. And we also, if you want to see our hype video again, you can actually see that. And then if you have any information or questions in relation to some of the work that we do, I have also provided our website as well as my email address and phone number. So with that, I want to thank everyone for attending today. And I'd like to allow Mr. and Mrs. Sanders to have the last dibs after we do our polls. So if we can get our polls up, and we'll ask everyone if they can answer those. And I'm not sure if we have any giveaways today or no, but we'll kind of see how everyone answers. So as you answer the questions on the poll, please make sure you scroll down. There's 7 questions. And so do make sure you try to answer all of them. Give you a few seconds for that.
Maybe it's because I'm a panelist, but I can't answer them.
Yes, usually the panelists can't answer. But once everyone answers, we'll be able to see how they answered. And so there was some very valuable information shared from several of from our speakers today. So we'll see how many of you recall what they're saying. Give a few more seconds. And I'm not sure if, Mr. Adams, if you can tell how many people have answered. We've got about 28 people still on. And we thank you for sticking it out with us.
They probably need like 30 more seconds because.
All right. So I think these first few questions kind of reflect some of the content Ms. DeVore just got through talking about. So pretty soon it'll show us the results and we'll kind of see what you all said. And if you have any other questions, please feel free to put them in the chat or the Q&A section. All right, Mr. Adams, we'll wait on you to showcase the results.
Okay. Make sure when you answer the questions that you hit submit. Yeah, okay, so they're starting to come up.
Okay, great. All right, so the first question, let me see, it's best to only involve the potential subject in the screening process, and throughout the study, family members and partners can be a distraction. And actually, I'm gonna let Ms. DeVore, I will let our speakers kind of give the right answers. It looks like we got half said true and half said false.
It is best to involve the family members, friend, someone else in the process. Family members are not a distraction. Partners are not a distraction. A potential subject needs their support. So that's a false statement.
Great. All right. And then the next question, only the physician who should know the ongoing health status of the subject during a clinical trial is the principal investigator, even if the subject specifically asked the staff to keep the other doctors informed. And it looked like 86% of them said false, and that's correct. We want all the caregivers or care providers involved, right?
Yep, that's right.
Good. Next one, clinical trial staff must be compassionate and patient with minorities, as they are often fearful of participating in clinical trials, and it's best to involve the family members and others throughout the process. And I think they did really well on that. Everybody got that one right. Okay, and which of the following is or are not contributors to how mistrust of health providers contributes to health disparities? So Ms. Nas, this looks like one of your questions. And the majority of them said all of these are contributors as to how mistrust occurs. I think they did pretty good on that one, huh? So I think they were listening there, but yes, definitely. Well, typically all of these can contribute. So which of the following is not true about participation in clinical trials? And 71% of you felt like all of these choices, are true. Let me see. Yeah, are true. So participants, I do want to just say that if you participate in a trial, you do get top-notch care. You're getting all of the lab tests and imaging and screenings and things. So if you don't have money to pay, that's a good thing. You get top-notch care.
Hey, Dr. Hill?
Yes, sir.
Hey, can I add on very quickly to that statement you made?
Sure.
Yeah, at the very beginning of the pandemic, when the COVID-19 vaccine trials were going on around the world, not only were people getting care that they had not gotten before in parts of the world, but that's when we really found out that the true answer to whether or not the vaccines could have any potential for women not becoming pregnant. Because during the clinical trials, even though you could not be pregnant when you entered the clinical trial, scores of women all around the world became pregnant after they entered the clinical trial. And then they had research teams kind of just fall upon them and follow them and they got Rolls Royce level care all across the world, care that they had not gotten before. So I think it's a very important thing for many people to understand that your health care, is going to be enhanced one way or the other during a clinical trial.
Exactly, exactly. And the next comment, Sharon did talk about participants can be compensated for their travel and involvement, their time, et cetera. And people can withdraw their consent, if they just want to stop participating for whatever reason. So you're not obligated to stay the entire time during the study if for whatever reason you want to get out. The next question, Ms. Nas didn't get a chance to really talk very much about Henrietta, but we'll see how they answered this one. So the question was, there's many concerns and layers with the story of Henrietta Lacks. In the research context, what was the concern? So we had 14% said her tissue was taken and used for research purposes, 43%,
Without consent.
Without consent, yes, I can't see the rest of the question. And then the next one was the cells proliferated over time and continued to serve the scientific community. And then the HeLa cells were one of the first human cells to be in outer space. And or was it that her family didn't provide consent post-mortem? So what's the real answer on that one? Okay.
It was taken without her knowledge, without her consent at the time whatsoever.
Yeah, and unfortunately, that's been considered the root for why people don't, want to participate in research. But now we have processes in place to avoid those kind of things from happening.
It's an amazing book. If anybody hasn't had a chance to read The Immortal Life of Henrietta Lacks.
Very good book, very good book. Okay. And then your next question was, what's the best way that we as providers and research staff can rebuild trust? And your choices were recognize that these are holistic beings with different perspectives and treat them with compassion, or compare to where they are in the scenario and not the other way around. Listen authentically, be equitable, and ensure that they have proper access to studies when developing a study design, or E, all of the above. So about 57% answered correctly. And actually all of these things are really important to rebuild trust. Well, they did a really good job on the questions for the most part. And I don't see where anyone else had any other questions. And if not, we will let Mr. and Mrs. Sanders go ahead and close us out. But we want to again thank everybody, Dr. Snead, Mrs. Nas, and Mrs. DeVore for your input and insights today. Great job. Thank you.
Here we want you to pick someone as the $50 gift card winner. Pick a person.
We're on mute, Dr. Hill.
What about Mrs. Is it Lauren? I picked the name I didn't know.
Yeah.
Okay.
Where does I see her?
It's Bryant.
Lauren Bryant.
Lauren Bryant.
Okay. We're going to need her address sent to, and I'll put it in the chat. You have psoc@yahoo.com. So we'll put that in for everyone. PEASOC. That's Spider-Man right there.
Okay.
So send your address to him, Lauren. Oh, this is incredible. Dr. Snead, Dr. Hill, Nina Nas, Sharon DeVore, Pastor Stafford. I am speechless. You don't get that often. This was wonderful, wonderful. Everyone hit a button. Each and everybody hit buttons all over the place. This is what we're looking at. The second commandment is not them. We've got to look at us. And I think you really made that point. Thank you. And the first commandment as well. Take it to the streets.
We're gonna close out with Dr. Lester Singleton giving us the benediction.
We have to give, Terrence, can you give Dr. Singleton a voice here? Is Dr. Stafford still here?
He's still on. He's still on.
Hold on. Is Dr. Stafford still here, Angela? I guess
He's still on. He's still on.
Is he still on? Then
Yes,
let your
yes.
pastor do the benediction.
Okay, all right, Pastor Q.
Okay.
All right, let us pray. Father, we're grateful for the information that has been learned today. Father, just in listening to this, we're reminded of the Good Samaritan, dear Lord. Father, I pray that we would be about helping those who are in need, bandaging wounds, creating awareness and safe spaces, dear Lord, that people can live and be well, that our souls shall prosper, dear Lord, even as we prosper. Oh, we thank you for WeCARE, 50 Hoops, and those who are helping to be a blessing, Lord, to those who are less fortunate, in need, in the need of practical care and provision. Father, bless efforts, bless what we do, and bless those to just encourage those to continue to do your good will. In your blessed Son name we pray. Amen.
Thank you, Pastor.
Amen. Thank you all and have a wonderful weekend.
Thank you.
God bless.
Thank you.